Hi, my name is Ingrid. I'm going to be going over female orgasmic disorder. So before I get started with FOD, I'm going to go over what orgasms are. So orgasms are marked by involuntary rhythmic muscle contractions throughout the body, as well as a sense of euphoria and a feeling of tension relief. Although not all men and women necessarily reach this stage, it is the peak of sexual climax or excitement. FOD is characterized by a difficulty experiencing orgasm and or markedly reduced intensity of orgasmic sensations. Although it may still need to be cared for, orgasm difficulties as a result of inadequate sexual stimulation do not receive a diagnosis of female orgasmic disorder. Additionally, if the individual is experiencing orgasm through clitoral stimulation but not during intercourse, a diagnosis of FOD is not made. This is because many women require clitoral stimulation to require orgasm, and a relatively small proportion of women report they always experience orgasm during penile-vaginal intercourse. Now moving on to the DSM-5 diagnostic criteria. Criterion A states presence of either of the following symptoms and experience on almost all or all occasions of sexual activity is either 1. Marked delay in, marked frequency of, or absence of orgasm, or 2. Marked reduced intensity of orgasmic sensations. There's criterion B. Symptoms in criterion A have persisted for a minimum duration of approximately 6 months. Criterion C. Symptoms in criterion A cause clinically significant distress in the individual. And in criterion D, the sexual dysfunction is not better explained by a non-sexual mental disorder or as a consequence of severe relationship distress or other significant stressors, and it is not attributable to the effects of a substance, medication, or another medical condition. Development and course. First experience of orgasm can occur any time from the first period to well into adulthood. Women show a more variable pattern in age at first orgasm than do men, and reports of having experienced orgasm increase with age. And many learn how to experience orgasm as they experience a wide variety of stimulation and acquire more knowledge about their bodies. Lifelong FOD, meaning orgasm difficulties that have always been present, can be resolved if caused by inefficient stimulation or by a woman's lack of knowledge or comfort with her body. Acquired FOD is difficulties that develop after a period of normal orgasmic functioning, and this can be resolved if the causative factors retreat on their own or are successfully addressed. Now on to prevalence rates. Orgasm problems in premenopausal women vary widely from 8 to 72%. However, these percentages do not take into account the presence of a distress. For female orgasmic disorder specifically, approximately 16 to 25% of women experience the disorder, with some studies reporting higher rates in women over 50. There is variation in how symptoms are assessed, such as symptom duration and recall period, and this influences prevalence rates. There is also risk and prognostic factors. There is temperamental, which is psychological features such as anxiety and concerns about pregnancy, which can potentially interfere with the woman's ability to experience orgasm. And then environmental, there is a strong association between relationship problems, physical and mental health, or orgasmic difficulties. And then social cultural factors such as gender role expectations, and religious norms are also important influences on the experience of orgasm difficulties. There's also genetic and physiological factors. Physiological factors are going to be such as medical conditions and medications such as multiple sclerosis, pelvic nerve damage from radical hysterectomy, and spinal cord injury. There is also selective serotonin reuptake inhibitors, which are known to delay or inhibit orgasm. And then women with vulvovaginal atrophy, which is vaginal dryness, itching, and pain, are significantly more likely to report orgasm difficulties than a woman without this condition. Now on to cultural considerations. The lack of orgasm in women is regarded as a problem that requires treatment that may vary depending on cultural contexts. Treatment seeking may be influenced by different cultural factors, especially in male-centered cultures. Views that undervalue women's sexual satisfaction or that perceive marital sex as a duty for women rather than a pleasurable activity are associated with lower help seeking. And then this may inhibit women from educating themselves about their sexual health concerns. And then there's also the issue that women differ in how important orgasm is to their sexual function. And then lastly, religious factors and associated guilt about sex may be implied in women with female orgasmic disorder. Now on to etiology. Understanding the cause of female orgasmic disorder is complicated by identifying the source of stimulation and reliance on women's self-report. What I mean by this is that some believe that they reach orgasm through penile-vaginal intercourse, yet in most cases it's due to simultaneous stimulation of the clitoris. And for genetic factors, twin studies have suggested the range of orgasm frequency variation could be attributed to genetic factors at 31 to 51%. Mood states such as anxiety that interfere with attention to sexual sensation and stimulation are not uncommon in women who struggle with this disorder. There is also social and environmental factors such as childhood or sexual abuse. There is women that live below the poverty line who report higher rates of inability to orgasm than women who live above the poverty line. There is communication deficits with partners, which is the most consistent correlate of orgasmic disorders. And then intra-individual factors associated with other female sexual dysfunctions may also play a role in FOD, such as anxiety, depression, cognitive distraction, body image appreciation, and childhood victimization. And now on to past theories / models. I'm going to go over Freud's psychoanalytic theory and Master and Johnson's 4-stage linear model of human sexual response. So Freud's psychoanalytic theory developed the belief that the shift from clitoral to vaginal erotic zones is seen as biologically imperative for reproduction and heterosexuality. It also posited that women who required clitoral stimulation to reach orgasm were psychologically less mature or superficial and immature than those who could reach climax during intercourse, who he viewed as authentic and adult. And the failure to achieve vaginal orgasm became a key aspect of defining frigidity in women. Now on to Master and Johnson's 4-stage linear model of human sexual response. I do want to note that this is not FOD focused, but it's relevant to understanding female sexual response and factors that may contribute to difficulties in achieving orgasm. So it goes from excitement to plateau to orgasm and then to resolution, which is just back to baseline. However, this model was heavily criticized for being too narrow in conceptualization, and it doesn't fully capture the complexity and variability of female sexual experiences. Now on to current theories and models. There's the biopsychosocial model, and then Bassin's nonlinear model of female sexual response. So for the biopsychosocial model, there's obviously the biological factor, which is neuropsychological factors are implied as potential causes of orgasm difficulties. Psychological, emotional states positively associated with sexual problems with women. And then depression may reduce sexual desire, which in turn can directly lead to orgasmic disorder. And then social, there's a strong negative correlation between spousal dissatisfaction and orgasm difficulties. However, just as the DSM-5 makes note of, if the difficulties where orgasms are best explained by these factors, a diagnosis of FOD should not be made. And then there's Rosemary's nonlinear model. She developed this as a response to the previous linear model. And here we have interest and desire, arousal, sexual behavior, and satisfaction to resolution. However, resolution doesn't necessarily entail a complete absence of desire. It can go immediately back into interest and desire. This is important for understanding female orgasmic disorder because she recognized the difficulties in achieving orgasm may be influenced by various factors at different phases. It acknowledges variability and difficulties in achieving orgasm, which may be required to tailored interventions. And it provides an individualized approach to understanding and addressing orgasmic concerns prior to giving an FOD diagnosis. So this is what I mean that it's no longer a linear model. And then also the desire could start whenever. It could either begin during or before the sexual activity itself has begun. And then for assessment, so sexual dysfunctions can be highly comorbid with each other. Current and preferred sexual activity and satisfaction should be evaluated along with the distress. And then there's just a list of detailed descriptions that should be documented, such as arousal, orgasm, sexual satisfaction. And then one of the instruments that can be used is ORS, or Orgasmic Rating Scale. It uses a multidimensional approach to assess and quantify the psychological experience of orgasm. It's a 40-item self-report scale. It has 2 subscales, and it describes 2 sexual context conditions. Then there is also the female orgasm scale, which assesses the consistency of female orgasm during partnered sexual activities and oversatisfaction with orgasm frequency and quality. It's a 5-item scale. 5 items inquire about orgasm during various different occasions and stimulations. And then the last 2 assess perceived satisfaction with the number and quality of orgasms experienced with your partner. And then these scores have to be weighed because they are tallied differently. And then the differential diagnosis, we have non-sexual mental disorders, substance medication-induced sexual dysfunction. If the onset of the problem coincides with usage of substance and medication or discontinuation, there's a separate sexual dysfunction provided. Another medical condition, interpersonal factors, and other sexual dysfunctions. The presence of another sexual dysfunction doesn't rule out FOD, but FOD is still not appropriate if the problems are a result of inadequate sexual stimulation. And then we have treatments. There's no FDA-approved agents to treat FOD. There's no FDA-approved agents to treat FOD safely or effectively. The prescribed pharmaceuticals are off-label, so that means that the individual is being prescribed an FDA-approved drug for a different condition. One of the treatments is education about women's sexual response to sexual anatomy, directed masturbation, sexual skills training. The most commonly used and most effective treatment is cognitive behavioral sex therapy, which focuses on altering negative attitudes towards sexuality. And then Sunset Focus, which was developed by Masters and Johnson, which is a 5-step process to improve intimacy and communication between partners. So this is the case presentation. We have Maeve, who's a 30-year-old woman. She reports that on almost all occasions of sexual activity with her long-term partner, she experiences marked delays in reaching orgasm, and this issue has persisted for the past 9 months and has been causing significant distress in her personal life. And the inability to experience sexual climax has led to feelings of inadequacy and an over sense of frustration. She says she has a regular and satisfying relationship with her partner, who is understanding, supportive, reports no history of mental disorder or significant mental condition, along with no use of substance or medication. And her diagnosis would be at 52.31 female orgasmic disorder acquired. So going through the DSM-5 criteria. For criterion A, she experiences marked delay in reaching orgasm during almost all instances of sexual activity. Her symptoms have persisted for 9 months, which meets criterion B, and she reports significant distress in her personal life, such as feelings of inadequacy and frustration. And then for criterion B, it's not better explained by non-sexual mental disorder, a consequence of relationship distress, or to the effects of substance and medication usage. And then for a differential diagnosis, she has no reports of mental history disorder. However, it would be important to evaluate her for any current or recently developed mood disorders. For interpersonal factors, she has a regular and satisfying relationship with her partner. However, we need to look at any other significant stressors outside of the relationship. And then other sexual dysfunctions should be assessed for prior to a FOD diagnosis. And then these are my additional readings in the handout and my references, and thank you for listening to my presentation.